Good evening, everyone. So, thank you for that amazing response for my demo video, and it was truly overwhelming. So, I thought I'll do some videos based on my case scenarios which I encounter in my daily clinical practice. So, this would be useful both for the postgraduates and also the budding magicians. So, why delay? Let's move on to the case which I saw. So, here is a pregnant mother who is a primigravida with 8 months of amenorrhea. She visited the OPD with pain abdomen and with history and examination, we came to a probable diagnosis that she is a primigravida of 34 weeks 6 days period of gestation with cephalic presentation, and she had severe preeclampsia with preterm labor. So then she was admitted to the labor room, and her BP was admission BP was around 160 110. So the loading dose of magnesium sulfate was given, and following that, even the Zuspan regimen was on flow. She was also given IV labetalol, increasing doses. So with that, after 4 doses of labetalol, still her BP was persistently high. So a decision was taken and an emergency cesarean was performed in view of preeclampsia with severe features with unfavorable cervix. Post-operatively, her course was uneventful, but the simple fact that she was still having high BP readings and post-operative antihypertensive was also started, that is tab amlodipine 10 mg BD, and with that her BP was almost within normal limits. So 3 days back, I visited the postnatal ward for my evening rounds. So this patient was post-op day 7 of emergency LSES, and she was complaining of breathlessness. So I asked her from when she had breathlessness. She told it was for about 30 minutes. It is also associated with chest pain. So she was anxious, and then we put her up in proper position. We checked her pulse, and it was around 130. Her BP was around 120/80. Her respiratory rate was 32 cycles per minute. Her saturation in room air was around 95/96. So a decision was made, and she was immediately shifted to HDU. And she was started on oxygen. An intensivist opinion was sought. We did a baseline ECG, which showed sinus tachycardia, and a chest X-ray was done, which showed a mild pleural effusion and also increased bronchovascular markings. Then we did a 2D echo, so which showed LV dysfunction and mild global LV hypokinesia, and ejection fraction was around 45%. So immediate physician and cardiology opinion was sought, and we wanted to diagnose what could lead to this. So now let me discuss what are the differential diagnoses of a case who presents to you with breathlessness, either during pregnancy or post-delivery. So what could be the cause? So this we can divide into three different headings. So what are they? The first, so we can think that the dyspnea could be physiological. So we all know that certain respiratory changes occur normally during pregnancy. So what are they? The respiratory rate, though it remains normal, there is slight increase in tidal volume. So the minute ventilation also increases. So certain times there might be mild dyspnea, which is not associated with any other symptoms or signs, and it is completely physiological. And also during third trimester, due to the respiratory embarrassment of the gravid uterus, still the mother complains of dyspnea. So this is completely physiological, which is called as dyspnea in pregnancy, which is completely physiological. So what are the other causes of dyspnea which occurs during pregnancy or the post-delivery period? So we can think and we can differentiate that it could either be due to cardiological causes or cardiac disorders or pulmonary disorders or the combination of both. So how do we differentiate? Firstly, history is a very important thing. So history plays a pivotal role to differentiate between a cardiac cause and a pulmonary cause, or a pulmonary cause which is ending into a congestive cardiac failure. So how do we differentiate? So at the level of history, the mother is presenting with you with only dyspnea. Ask the associated symptoms. So is there chest pain? Is there orthopnea? That is dyspnea which exerts more during supine position. So it exaggerates in supine position, that is orthopnea. And if it is more during the night times, so that is called as paroxysmal nocturnal dyspnea. So all these go more in favor of a cardiac cause. What about the respiratory cause? So then we have to ask whether she has any history of allergy or atopy or an airway disease, or whether she complains of any chest tightness which is associated with dyspnea. So this goes in more in favor of a pulmonary cause. So this is at the level of the symptoms. Next, we have to know what examination will help us to differentiate between a cardiac cause and a pulmonary cause. So firstly, we have to examine her. We have to do a general physical examination. We have to see whether there is any pallor. So it could be severe anemia, which is leading to congestive cardiac failure, which is also one of the reasons for dyspnea during pregnancy or after childbirth. Next, we have to see whether there is cyanosis or clubbing. So these also are the physical signs which goes in favor of a cardiac cause or a pulmonary cause. Then we have to see whether there are any swelling of lower limbs. So usually swelling of lower limbs or grade 2, grade 3 edema goes in favor of a cardiac cause whenever there is heart failure. The fourth important thing is we have to see the jugular venous distension. So if this jugular veins are distended, this also could be one of the feature of cardiac failure. Then we have to see whether the mother is using her accessory muscles to respire. So this could be some of the restrictive pulmonary causes like COPD. So general physical examination reveals so much to diagnose what might be the cause for this dyspnea which has occurred. So moving on to the systemic examination. So we have to auscultate her chest. So we have to do a thorough CVS examination, that is cardiovascular examination, to see whether there are any murmurs. The small functional flow murmur is physiological during pregnancy. But if there are any loud systolic murmurs, if there are diastolic murmurs, if there is presence of S3, if there is splitting of second heart sound, these definitely cannot be neglected. So these all go in favor of a cardiac cause, whether it could be a congenital cardiac cause or it could be a acquired heart disease. So next, moving on to the examination of respiratory system. So we have to see whether there are any presence of added sounds, whether there are any crepitations, whether there are any V's which we can hear, whether it's inspiratory or expiratory. So these are also an important factors which lead to the diagnosis of the condition. So this is how, at the level of history and examination, we can easily differentiate between a cardiac cause and a pulmonary cause. Next step is doing some basic investigations. So what are these basic investigations which are important when a mother presents to you with dyspnea? So the first important thing is doing a ECG. So it will show us any abnormalities in the pattern. So if there are any T wave inversions, if there are any long Q waves, so these show us that ECG is a very important investigation to diagnose the cause for dyspnea, followed by a chest X-ray. So we will be able to diagnose a pulmonary edema, we will be able to diagnose pleural effusion, we will be able to see if there are any fibrosis, which was antecedental cause due to any pulmonary fibrosis or tuberculosis in the past. And then the third important investigation is by doing a 2D echo. So this echo also will help us identify the cause for this condition. So then, based on these preliminary investigations, we can rule out what might be the differential diagnosis. So I told you the first important cause is dyspnea, which is normally physiological in pregnancy. The second important thing in cardiac causes could be any congenital cardiac cause or an acquired heart disease like valvular lesions in the heart, peripartum cardiomyopathy, which is a very important differential diagnosis. If a woman presents to you with dyspnea in her last month of pregnancy or the first 5 months after her childbirth. So this is also a very important differential that we have to keep in mind. The fourth important thing is venous thromboembolism, especially in cases who have risk factors. So in our case also, she had many risk factors. So pulmonary embolism has many risk factors which we have to evaluate based on the RCOG risk factor analysis. So this risk factors analysis should be done both in the antepartum period and also the postpartum period so that we can start thromboprophylaxis and prevent this venous thromboembolism. But if she is already presented it to you with venous thromboembolism, so firstly we have to do an ECG, an X-ray, and if there are any abnormalities or if there is any DVT which is a highly suspicion by clinical evidence, then we can do a compression duplex ultrasound and confirm DVT. So that is how we diagnose which investigations to be done in which condition. So these are some of the cardiac causes. So what are the pulmonary causes? So if the patient presents to you with dyspnea, so the pulmonary causes would be when the patient has any history of asthma, so acute exacerbation of asthma, any infection, so pneumonia, which is also going into breathlessness, then pulmonary edema, and whenever there is raised pulmonary artery hypertension. And sometimes a pulmonary cause would cause more strain on the heart and might lead to congestive cardiac failure, which also causes a cardiorespiratory failure where the woman also presents to you with dyspnea. So this is how we have to clear cut, we have to have a clear cut idea of what might be the cause for dyspnea. So whenever we identify the cause, the diagnosis is very important for their further management. So in our case, what we did, so we did a 2D echo. So this was showing a global hypokinesia and also the ejection fraction was slightly less. So we decided to go to a next level by doing the blood test. So our unit chief suggested to do a blood test, that is BNP. So these are natriuretic peptides which are elevated in cases of peripartum cardiomyopathy. So as we suspected, the BNP was very high. So what we did, so we made a provisional diagnosis of peripartum cardiomyopathy. So in this video, we will discuss what is peripartum cardiomyopathy. So what are the risk factors associated with it? How will we diagnose and how will we manage? So in our next video, we will diagnose or we will evaluate and diagnosis of venous thromboembolism we will discuss. Okay, so let's move forward. So we'll discuss about peripartum cardiomyopathy. So what is our agenda? We'll discuss under these important headings. So introduction to peripartum cardiomyopathy. What are the epidemiology and risk factors associated with it? What is the brief pathophysiology? And how does the patient present to you with clinically? And what are the differential diagnosis? How do we investigate and manage a case of peripartum cardiomyopathy? And what are the final tips and takeaways and a take-home message about PPCM? So how do we define peripartum cardiomyopathy? So it was defined by European Society of Cardiology in 2010 as it is an idiopathic cardiomyopathy which occurs in pregnant women or in postpartum, that is first 5 months after childbirth or during the last month of pregnancy, and the woman presents to you with left ventricular systolic dysfunction and no other causes of heart failure can be found. So it is actually the diagnosis of exclusion. So usually the peripartum cardiomyopathy presents with the left ventricular ejection fraction of less than 45%. So what are the incidence of this condition? So usually the incidence is around 1 in 1000 to 4000 population. But in certain races and countries like Nigeria and the African race, the incidence is slightly higher. So the incidence is around 1 in 100 births. And what are the other risk factors for peripartum cardiomyopathy? So multiparity, advanced maternal age, history of preeclampsia, chronic hypertension, and obesity, All these are risk factors for peripartum cardiomyopathy. And usually the preeclampsia and peripartum cardiomyopathy have more common incidence because they have an overlapping pathophysiology. So, moving on to the pathophysiology. So, the present consensus tells that the PPCM is multifactorial. So, the first theory which was put forward was a genetic theory. The women with certain genes are implicated to have a predisposition for development of peripartum cardiomyopathy. So, what are these different genes? So, the first gene is TTN. The second one is TTNCI. The third one is BAG3. So all these genes are implicated in causing a predisposition of this disorder. The second model which is used to describe the pathophysiology is the vascular and hormonal model. So what happens is, so listen carefully. Firstly, there is some transcription factor called STAT3. So this transcription factor increases at the end of pregnancy and childbirth. So some times when there is this genetic predisposition, this STAT3 reduces. And whenever there is reduction of STAT3 transcription factor, this acts like a predisposition for development of increased free radical injury. So this is a cathepsin D which is depicted in this picture, and this cathepsin D cleaves the prolactin which is also raised at the end of pregnancy and childbirth, and this prolactin is cleaved into an abnormal prolactin called as 16 kilodalton prolactin, and this fragment causes endothelial dysfunction and also the cardiomyocyte death. And also there is some other implication called there is increase in microRNA 146A, and this also causes endothelial dysfunction. And the third thing is an imbalance between the proangiogenic and anti-angiogenic factors. So usually this also we see in the immunological theory of preeclampsia. So there also we have seen that the anti-angiogenic factors increase and the proangiogenic factors decrease. So this SFLT is an angiogenic factor. So this increases and the VEGF decreases. So whenever there is this disturbance between the proangiogenic and anti-angiogenic molecules, this also causes endothelial dysfunction. So this causes cardiomyocytes to die. So whenever this dysfunction causes the death of the cardiac cells or cardiac myocytes, the heart chambers start dilating. So that is why PPCM is a type of dilated cardiomyopathy. So what are the very important symptoms which the mother presents to you with? So these are the three very important symptoms which needs evaluation. So dyspnea, orthopnea, paroxysmal nocturnal dyspnea, and other important symptoms are chest pain, dizziness, palpitations, unexplained dry cough, and these are also some of the symptoms which the patient could present to you with. And further, we have to do a detailed examination. So what are the clinical signs which we should be able to elicit when there is a suspicion of PPCM? So those are tachycardia, tachypnea, raised JVP, peripheral edema, crepitations, and also sometimes the presence of S3 also could be there to diagnose. So all the signs and symptoms of peripartum cardiomyopathy mimics systolic dysfunction, especially the left ventricular systolic dysfunction or the left heart failure. Now let's discuss. So whenever the mother presents you with these symptoms and clinical signs, our further evaluation should be there to diagnose the condition. So what are the investigations which we have to do? So this chart clearly explains of what has to be done and how to manage. So usually if the mother presents to you with shortness of breath towards the end of pregnancy or postpartum period, we have to do natriuretic peptides. So before doing natriuretic peptides, we will do a preliminary ECG which might reveal sinus tachycardia and sometime non-specific ST elevations and T-wave abnormalities. And also we can do a chest X-ray to rule out other conditions like pleural effusion and pulmonary edema. So after this preliminary investigations, we go and do a natriuretic peptides, that is BNP or NT-proBNP. And also we do a echocardiology, that is 2D echocardiogram. Then, based on these, we can diagnose and confirm peripartum cardiomyopathy. So, if the BNP is more than 100 picogram per ml or NT-proBNP is more than 300 picogram per ml and the ejection fraction is less than 45%, we have to definitely involve cardiology. So, it is a multidisciplinary team approach, and we have to consider PPCM and other cardiovascular differential diagnosis. So this is very important. And if the natriuretic peptides turn out to be normal and if the ejection fraction is more than 45%, PPCM is very unlikely, and we have to consider other non-cardiovascular diagnosis for evaluation of breathlessness. So this is a very important algorithm for management of PPCM. So this I have taken from a TOG article of Peripartum Cardiomyopathy, which was very recent, that is in 2021. So it's an RCOG article. So how do we go about? Firstly, look at this algorithm and observe. So in this entire picture, we will be able to manage a case of peripartum cardiomyopathy. So whenever there is acute heart failure in pregnancy, firstly, we have to confirm the diagnosis. So how will we confirm? By doing an ECG, blood tests like natriuretic peptides, chest X-ray and an echocardiograph. After that, if the mother is still pregnant and if her period of gestation is more than 24 weeks, then we will give antenatal corticosteroids for fetal lung maturation. So usually this PPCM as such occurs in the last 1 month of pregnancy. And always, whenever there is acute heart failure, it is not a single person who is going to be managing a case. So it's a multidisciplinary approach. So who it involves is, it involves an obstetrician, a cardiologist, a neonatologist, an anesthetist, and an intensivist. And also we have to assess the severity of heart failure. So we have to see what is the systolic blood pressure. Is it less than 90? Whether there is tachycardia, that is the heart rate is more than 130 beats per minute. If the respiratory rate is more than 25 cycles per minute, if there is increase in serum lactate, is there persistent desaturation, or if there is any altered mental state, cold skin or oliguria, where these are all features of hypercapnia, that is the SpCO2 is more than 60% or SpO2 is less than 60%. So this time we have to assess the severity of cardiac failure. So we have to see if there is severe acute heart failure or cardiogenic shock, we have to maintain the optimal preload. So we have to give the ionotropes. Also, we have to maintain the balance between the input and the output. So the preload and afterload balance should be maintained, and such that the systolic blood pressure is more than 110 beats per minute. And we have to firstly optimize the oxygenation, and we have to consider NIV, that is non-invasive ventilation if necessary, and invasive ventilation if the saturation is dropping less than 92%. And we have to also add ionotropes and vasopressors. So one of the very important ionotropes is levosimendan, which is given in the dosage of 0.1 microgram per kg per minute. And this necessitates urgent delivery because pregnancy is a risk factor and it exaggerates the heart failure. So we have deliver her if she is hemodynamically unstable. And we have to also consider bromocriptine after delivery, because bromocriptine is a dopamine agonist, which is a antagonist for prolactin. So this has to be considered. And we have to also consider mechanical circulatory support if the mother is gone into decompensated shock or if she's gone into an unstable state. So if the patient recovers, then we can wean off her, or sometimes it might be a indication for transplantation or LAD assist devices. So if the mother is in the antepartum period, we have to time her delivery, whether we can prolong the pregnancy or we have to immediately deliver her. So if there is a deteriorating maternal condition, we have to immediately deliver her and we have to go for advanced heart failure therapy. If the mother is in stable condition, then we can add certain drugs like ACE inhibitors and ARBs, but they are contraindicated in the antepartum period. So the drugs which can be used in pregnancy are hydralazine, nitrates, beta blockers, and sometimes if there is Krebs and pulmonary edema, we can get diuretics also. And this also has to be a multidisciplinary team approach. And if we are delivering her, a vaginal delivery is always better in a stable patient. But if she's unstable, that time it is better to go for a cesarean delivery. And in the postpartum period, we can use certain drugs called ACE inhibitors, ARBs, beta blockers, which are safe in breastfeeding. And also these are the very important heart failure medications which has to be given to decrease the preload and afterload and to decrease the stress of the heart to prevent cardiac failure. And the considerations of when to consider bromocriptine is to be very important. So, next important thing is whether we have to consider breastfeeding or not, because we have told that prolactin also is implicated in the pathophysiology. So, feeding the baby, does it deteriorate the condition, is a big question mark. So, what is the recommended consensus? So, presently, if the mother is in an unstable condition, if she's in CCU or her left ventricular ejection fraction is less than 45%, then breastfeeding is contraindicated. But if everything is normal, if the ejection fraction is more, the mother is very comfortable and she's stable, then breastfeeding can be considered. And it is the same where whenever the breastfeeding is contraindicated, we have to give bromocriptine. So this bromocriptine is a prolactin antagonist. So what is the dose of bromocriptine? So usually we start with a dosage of 2.5 milligram BD for 2 weeks, followed by 2.5 milligram OD for about 6 weeks. The second important thing is whether thromboprophylaxis is indicated or not. Whenever the left ventricular ejection fraction is less than 35%, there are higher chances of formation of intracardiac thrombus. So in this condition, we have to give the low molecular weight heparin. And also whenever the mother is on bromocriptine, this is also one of the indication for low molecular weight heparin therapy. So usually it should be considered to continue the low molecular weight heparin until the mother stabilizes up to 3 to 6 months postpartum, and it is the clinician's discretion. So what is the prognosis of peripartum cardiomyopathy? So if the left ventricular ejection fraction is more than 50%, then 50 to 80% of the individuals or women will recover completely over the period of 6 months. But if the left ventricular ejection fraction is less than 50%, there might be chances of persistent left ventricular dysfunction disease where the ejection fraction will not improve. So this might be one of the very important risk factor or a contraindication for planning next pregnancy. If the left ventricular ejection fraction is less than 25% and if there is persistent dysfunction, it is a contraindication for planning a next pregnancy, and they have to be counseled to avoid pregnancy and the contraception to be used. And it is very important for us to address the woman in the subsequent pregnancy also. So she requires a thorough preconceptional counseling. We have to repeat her echo to see how much recovery of the LV ejection fraction has occurred. So a clinical assessment, an echocardiogram, BNP should be performed at regular intervals and if the patient has any other concerning symptoms. So this flow chart shows us that prior to conception, we have to meet her once at the end of first trimester, second trimester, 1 month after, prior to the delivery, after delivery, just prior to the discharge, and 1 month after delivery, we have to continuously assess her. These serial assessments prevent any further deterioration of the mother and going into cardiac failure. So then this is a very important table which is taken from Journal of American Cardiology. So this also shows that the subsequent pregnancy should be monitored from the first visit till the delivery. So how will we manage her if the LV fraction is recovered, that is more than 50%, and if the left ventricular ejection fraction is less than 50%. So in the preconceptional risk counseling and the follow-up planning should be explained to the mother, and we have to tell that there is 20% chances of relapse, and in mothers who have less than 50% ejection fraction there is further deterioration and there is increased morbidity and mortality. As such, in PPCM, the mortality is about 10%. But if she goes into the subsequent pregnancy, the mortality can even more increase. And the medications which she is taking prior to conception has to be altered, and the ACE, ARB inhibitors has to be stopped when she plans her pregnancy. Instead of that, we can start her on beta blockers, hydralazine, diuretics, or nitrates, which are alternatives and safe during pregnancy, and even during delivery and labor, and multidisciplinary approach has to be followed, and a tertiary health center involving all the levels of specialties like intensivist, cardiologist, obstetrician, and senior midwives all must have to be there during the delivery of this mother because she is at a higher risk of developing heart failure. So this is my last slide, which shows the take-home message for this peripartum cardiomyopathy. So what all should we remember when it comes to peripartum cardiomyopathy? So it is defined as a non-ischemic cardiomyopathy with reduced left ventricular ejection fraction of less than 45%, usually in the first 5 months postpartum or towards the end of pregnancy, the mother will present you with. And mainly the risk factors are African American race, preeclampsia, hypertension, multigestational pregnancies, and advanced maternal age. And what are the symptoms? It is mainly the heart failure symptoms, which might be confused with other common symptoms of normal pregnancy. That's what we have to keep in our mind. Next, how do we manage? So during pregnancy, we can give beta blockers, loop diuretics, and we have to avoid ACE inhibitors, ARBs, and aldosterone receptor antagonists. And we have to follow a multidisciplinary team approach. And if she's going into congestive shock or failure, we have to aggressively manage her and we have to deliver her if she is unstable. Post delivery, we can shift to ARBs and ACE inhibitors, and we have to do a thorough hemodynamic monitoring, but we have to see the caution over the fluid overload, especially after delivery. And after pregnancy, we can give her heart failure management with respect to beta blockers, ARBs, and aldosterone receptor antagonists and anticoagulation if the ejection fraction is less than 25%. And if she has persistent dysfunction, there might be a wearable cardioverter or a defibrillator or LV assist devices. And we have to also discuss the contraception with her. So the contraception which is indicated are usually intrauterine contraceptive devices like Poppy or Mirena, which are safe. And the third important thing are progesterone implants or progesterone hormonal devices can also, like Mirena, can also be used, and progesterone tablets are also safe, but we do not advise combined oral contraceptive pills because we have a higher risk of thrombosis and embolism. And next, coming to the outcomes, usually the worst prognosis is only when there is reduced left ventricular ejection fraction, and African American race have a highest mortality. And whenever the diagnosis is delayed, this also might be causing more of morbidity and mortality. So what do we have to remember in respect to long-term outcomes? We have to see that after recovery, the optimal duration of medical treatment is unknown, that we do not have to know how many days she has to take her treatment. And in cases of stopping medications, we have to gradually stop it, and we have to continue surveillance even after recovery. We have to do periodic clinical assessment, echocardiography, to see if she is completely recovered. So this comes to the end of today's presentation. So I briefed of what are all the differential diagnosis of breathlessness during pregnancy and the immediate postpartum period. And also we have in detail dealt about peripartum cardiomyopathy, its definition, pathophysiology, management, and what are the take-home messages. So these are my different references and you can go through them. Thank you. Happy learning. See you in my next video.